is Joost Drent. I'm a gastroenterologist, hepatologist from the Radboud University Medical Center in Nijmegen. Let me explain why we actually did the study. We realized that with the advent of new direct antiviral therapy, we were actually able to cure a large set of patients with hepatitis C. Unfortunately, we couldn't cure as well the patients with genotype 3, as opposed to the patients with genotype 1. We did not really know which drug actually to use. What we did see in the literature that head-to-head studies were absent, and that we were really searching for evidence to which therapy would be actually the best. And that is exactly the reason why we started the study.
Hello, I'm Floor Burden and I'm a PhD student at the Department of Gastroenterology and Hepatology of the Radboud University Medical Center in the Netherlands. With this study, which was introduced before, we aimed to identify the best treatment for patients with hepatitis C genotype 3. So we assessed the comparative effectiveness of direct-acting antivirals, and furthermore, we wanted to assess the value of ribavirin in these patients. We did this by using a network meta-analysis. A network meta-analysis is able to compare treatments indirectly to each other. And we performed a systematic review to identify all the literature available at the moment. We were able to draw a network of all these studies. And this network we used to compare treatments indirectly. And we used a Bayesian statistics model for the analysis, and this model included the regimen, ribavirin, cirrhosis, duration of treatment, and interaction of ribavirin and cirrhosis, and also study effect. And we were able to identify the best regimen for patients with genotype 3 without cirrhosis, namely sofosbuvir plus velpatasvir and ribavirin for 12 weeks. However, there were also other regimens which achieved SVR rates above 95%, such as sofosbuvir plus velpatasvir without ribavirin, sofosbuvir daclatasvir plus ribavirin, and even sofosbuvir, peginterferon and ribavirin achieved high SVR rates in these patients. In patients with cirrhosis, the situation is somewhat different. Patients almost always need a 24 weeks duration of treatment. Sofosbuvir plus velpatasvir for 24 weeks was the best, then followed by sofosbuvir daclatasvir with ribavirin for 24 weeks. And the only regimen that achieved comparable SVR rates was in 12 weeks was sofosbuvir plus velpatasvir and ribavirin. Both for patients with and without cirrhosis, the sofosbuvir plus ribavirin combination for 24 weeks was clearly inferior. Overall, the role of ribavirin was clearly present. Both in cirrhotic and non-cirrhotic patients, ribavirin significantly boosted SVR rates with odds ratios of 2.6 to 4.5.
Well, what did we conclude? We found that for genotype 3 hepatitis C patients, the combination of sofosbuvir and velpatasvir works best. We also found that adding ribavirin to the combination actually boosts results. So to conclude, we thought that a network meta-analysis really brings out the data that is already in the literature. This helps us to define the best and the most optimal treatment for the patient. And it also helps us to prioritize treatments that you can use for our patients. Thank you for watching. It has been a pleasure to make it for you. Further details you can find in our article, which has been published by Clinical Gastroenterology and Hepatology.